Okay, so welcome. I am Dr. Judith Susan Rocha. That's the first time I ever used my middle name as my first name. Dr. Judith Susan Rocha, currently the interim MSW program director here at Northeastern Illinois University. We're very happy to have, this is what, oh my gosh, I don't know, 7th, 8th social work month session. We continue having these, and these are amazing. We've had a lot of great speakers, a lot of wonderful information that we've been able to share. If you haven't been able to make it out to the other ones, know that we have them recorded. So feel free to ask us about that information so you can definitely take advantage of some of that valuable insight that our folks have been offering in these. Here is in the chat, I will share the YouTube link so that you can share it across your networks. And I'll hand it right over to our outstanding student group that has been the mover and shaker in preparation for this presentation tonight.
All right, thank you so much, Dr. Rocha. Thanks everyone for being here. My name is Justin Wetstein. I use he, him pronouns. Last semester of my MSW program, current vice president of the GASSW, which is the Graduate Alliance of Student Social Workers. I'll talk a little bit more about that before we close, but thank you all so much for being here. It's been a pleasure to help co-organize and facilitate this event. Thank you so much to the faculty and the staff in the social work department at NEIU for supporting us in our, outside the box approach to social work education and how we, getting to do what we think is appropriate and not listening to just what's been told to us. So it's a total honor and pleasure to welcome these two speakers tonight. They are doing really important things here in Chicago, engaging in what we believe are like alternative responses that will hopefully change the face of social work as we know it, and leave room for interpretations that don't necessarily fit the standard kind of carceral models, or that leave room for us to kind of have autonomy and look at other things that are important when we deal with folks and systems. So I am going to introduce our first speaker, the lovely Elena Gormley. A little bit about Elena is that she is a writer, organizer, and MSW student at the University of Illinois at Chicago Jane Addams College of Social Work. She is specializing in organization and community practice. Elena has an extensive background in community organizing, advocacy, and being the problem client across multiple systems and treatment settings. These experiences drive her to abolish the entire social work profession and elevate systems of community care and support free from oppressive notions of gatekeeping and professionalism. As an organizer with Social Service Workers United Chicago, she has led and supported efforts to draw attention to unsafe and oppressive working conditions at agencies in Chicago, advocate for the defunding of the Chicago Police Department, and reallocate resources to social services, and co-authored Social Service Workers United Chicago's open letter and petition demanding that the NASW demand that the professional body end oppressive practices, including promoting police partnerships with social workers. That is actually a required reading in the MSW program at NEIU as well. Elena worked with a team of 4 other Jane Addams College of Social Work students and the Upend movement, the Shriver Center on Poverty Law, and Social Service Workers Uprising Now New York City to develop an alternatives to calling DCFS resource guide, which is a widely shared resource and is sparking national conversations on the need for mandated reporting law reforms and the abolition of the family regulation system. Her work has been assigned as required readings for social work students right here at NEIU, the University of Michigan, and the University of Chicago School of Social Service Administration. Elena has spoken on webinars, events, and trainings at the Shriver Center on Poverty Law, the network's 40-hour domestic violence training, the Lift the Ban Coalition, Movimiento Cosecha Michigan, and the Grand Rapids Feminist Film Festival. In her spare time, Elena enjoys long walks on the beach with her partner Dustin and her cat Sushi. So without further ado, we're going to bring it to Elena to present on the alternatives to calling DCFS guide.
Thank you so much for that glowing introduction, Justin. I have to say that this has been a very mind-boggling experience. I started my MSW journey Almost getting sick from anxiety on the train ride from Rogers Park to campus for student orientation because I was just so nervous. And this came about in part because Dr. Holtschneider, who co-authored one of my required textbooks, informed Justin, and thus I learned from Justin that the DCFS guide is a required reading for courses in the vulnerable population specialization. So this has been a very interesting MSW journey, and I just really appreciate you all extending this invitation. So let me just get my screen share set up. Can everyone see my screen?
Yes.
Fantastic. I think it my PowerPoint may have just frozen. No? Hang on. Technology is fabulous. So I know this is a provocative title. It is obviously a metaphor. Please don't kill people. But like there's, if you spend a lot of time in abolitionist spaces, people will use the phrase kill the cop in your head as a way that if you're going to be challenging police and prisons, you also have to do the internal work of challenging the way that you might police others. And of course, the thing about social work is we're having all of these conversations about alternatives to policing. And sometimes what happens is we forget that how much cop stuff our field does. Again, I would really like to extend my thanks to the NEIU Social Work Department and GASSW. My views are my own. They do not represent the institution I am currently attending. So kind of just like as was highlighted in my bio, I came to social work with a more skeptical perspective because client in a lot of settings for about 10 years prior to attending, and I had been doing a lot of organizing work. My class, which was 8 a.m. Human Behavior and Social Environment, Monday morning, we were asked to discuss our social work mission statement. And I essentially stood up, and I cannot find the text. Unfortunately, it has been misplaced and lost to the sands of time. But my social work mission statement was essentially, I want to burn everything down, which was somewhat affirmed by the professor. It's like, oh, so you're the person who wants to burn everything down. And the thing about doing macro work is that a lot of times you're told to like try to narrow your focus within like the macro work you want to do. And at least by the end of my first semester, I had determined to focus on burning down everything oppressive within social work. And of course, the thing is that when you focus on all of the oppressive aspects of current social work practice, as you start going through all of these layers, sometimes I use the metaphor of a matryoshka, you kind of get to the point of, okay, so do we just have to burn down the entire profession? Because a lot the oppressive practices just run so deeply. And of course, the thing about that is people do tend to get somewhat scared when you talk about this. And it's important to point out that, talking about destroying oppressive systems does not people want to cause harm. Of course, Dr. Gilmore, has said this the most eloquently, that abolition is about presence and not absence. And so really a lot of folks who do with a more radical perspective on social work, we're thinking about how can we provide really, the very needed care and support for individuals, groups, and communities without it being linked to cops and jails and psychiatric hospitals and the DSM and the family regulation system and the nonprofit industrial complex. How do we adequately compensate the people who have been doing this care work for millennia? Because the work of social work has been around ever since people got together and lived in communities. The current profession, which was developed because a group of very wealthy lesbians were trying to figure out how they could live independently in a socially acceptable way, is much more recent. And of course, the thing about like a lot of times throughout history, throughout these societies, this really necessary work has gone uncompensated. So how do we find ways to, compensate fairly all the people who are doing this work outside of the approved profession? And if the profession is going to still exist, how do we create more avenues into it that are not so, and I know I'm saying this at a university talk, but are not necessarily going through the BSW, MSW program system. And also, like, there's been so much discussion and organizing and movements around radical social work. And just want to point out the obvious that this is not a new idea. Radical organizing among social workers around the same timeline as other radical movements in the 50s, 60s, and 70s. A lot of those early movements were very explicitly in partnership with psychiatric abuse survivors, with parents directly harmed by the family regulation system. And then even prior to that, there is a more radical labor organizing history within social service work that doesn't get touched on a whole lot. You have in the 1930s, the Association of Federation Workers went on strike during the Depression, won back their lost wages. And one of the reasons why this particular thread of radical organizing tends to get ignored is because a lot of the social service worker unions were disproportionately impacted by the anti-communist purge within the labor movement in the 50s. The reason why you're seeing so much attention around this now is, as with all other current movements, we're building off of all of this work because of a convergence of factors, because of the pandemic, because particularly during the pandemic, the decades of moral rot within our profession are now really, really obvious. The devaluing of our labor is now very, very obvious. And of course, some very high profile touchstones were the NASW CEO really publicly promoting social workers partnering with police over the summer. And also when a lot of social workers called them on it, probably the most egregious example was Kim Young calling them on this and then getting blocked by the NASW's Instagram page. So that's kind of why we are at this convergence where there is so much more high profile attention towards radical and abolitionist social work. You are, and the reason why I'm here is because I have played a role in these efforts in concert with other people. I've been organizing with Social Service Workers United, and a group of us were just really appalled at the things that the NASW was putting out through the summer. And we got together, we just all went in on a Google Doc, and we drafted what became a really widely distributed Medium post, really specifically calling on the historic failings of the NASW, tying those historic failings to like the creation of the organization, because the way that the NASW really created itself was a way of devaluating the labor of social service workers, trying to separate social service workers from everyone else in really unhelpful ways, and included some very explicit abolitionist demands. It got 1,700 signatures. Like I said, it's been assigned as a required reading at NEIU, at Tulane, at Social Service Administration, and we know that it's gotten attention of quite a few state chapters of the NASW. We did submit all of the signatures to the national leadership and got completely cold shoulder ignored. And of course, having spent all of my summer involved in these high profile efforts around criticizing the field, I kind of brought that attitude to this project, which I collaborated with for other MSW students at UIC, and with Dr. Ellen Detloff, who's the Dean of the University of Houston's Graduate College of Social Work, with the Shriver Center on Poverty Law, and Tanya Gassenheimer, who is an attorney and has an MSW, and with a coalition of predominantly school social workers with SWOON New York City. So essentially, like, a lot of this work has been just public criticism, and also trying to create education and resources that can't be co-opted by any of these systems. The reason why my classmates and I focused on creating a resource guide was because that was the thing that all of the folks in Swoon's mandated reporting group were saying, we just wish we had something that laid out all of the issues with our state law that tried to walk people through how their biases might impact calls. So like we were just really like trying to, the same way we talk about the client as the expert of their experience, we're trying to like view, the people who are most concerned about this as the experts of their experience and kind of create a resource that responded to that. Someone, Justin, if you would just want to type in the bit.ly to the chat. So essentially, so we created this Alternatives to DCFS resource guide as a final project for a class. And just through the distribution, since we were distributing it to the two groups of people that tend to talk a lot for a living, which are social workers and attorneys, it really, those folks then shared it all over the place. And again, it really was developed because ANCRA was very, like the wording of ANCRA for like neglect was really vague. The thing that we kept hearing over and over again was the people who are, who have to make a lot of these calls because they are mandated reporters wanted more of a resource around critically thinking through the issues with these laws and trying to create a framework of providing support whenever it was feasible. And we did base this off of an extensive amount of literature. I'm just highlighting a few of the key pieces. The sort of landmark study was from 1999, which indicated that for the most severe cases of abuse, including bone fractures, those really egregious cases of maltreatment get underreported if the children being harmed are white. Washington University came out with a study that really just shows how wide this net gets cast. So 1/3 of all children will be subjected to a child welfare investigation by 18, and that number goes up to 53% of all African American children are subjected to an investigation before 18. And there's another fantastic researcher, Kelly Fong, who has really been doing a lot of really fantastic work around how currently, particularly during the pandemic, social workers and caseworkers in the child welfare systems being an arm of state surveillance is seen as a net benefit. It's not seen as a bug, it's seen as a really beneficial feature right now during the pandemic. And what she's been finding is there's a lot of times, a lot of the home-based services are based out of this push of, well, kids are not in school, so we can't keep track of families, which is kind of terrifying. My next slide is going to share a couple of examples that are local to Chicago that speak to both this over-reporting of families and also the under-reporting of harm. There are no images, but there are descriptions of some serious cases of misuse of this system and abuse of children. So I just want to let you all know that. So the first case has gotten a lot of widespread attention, and that is Janae Dodson, who is a teacher within Chicago Public Schools, had DCFS called on her son Braylon because there was, when school started up, there was an issue with transportation, which happens if you are a CPS parent. Her family member who picked up Braylon missed the 4:30 cutoff and picked him up at 4:37 instead. So DCFS was called. That call was screened in. An investigator did interview Braylon at school the next day, and now her son is expressing a lot of anxiety and reluctance to attend school because he is so scared that he's going to be separated from his mother. And Ms. Dodson is very concerned of what this could mean for her ability to remain a teacher if DCFS concludes that this is a sustained report. Another horrifying case is a coalition of groups, including Good Kids Mad City, that have been doing regular protests about the fact that DCFS and CPD repeatedly failed to intervene when they received reports that a 10-year-old girl was being repeatedly trafficked. And and like CBS2 has been doing, was the one that really brought this to attention and blew the whistle on it, and there's now an investigation. And it just really shows that sort of that over and under policing thing that also gets talked about within the criminal legal system. You have DCFS spending a lot of resources to police a wonderful mother who just had an issue with her transportation while really failing to prevent future harm of this 10-year-old girl who was being repeatedly trafficked. And of course, as a cynical person, you have to ask, is this system not working, or is this how the system is designed to work? Of course, the thing about this is, if you question mandated reporting, a lot of times there's a very immediate reflexive reaction that, well, if you don't call, every bad thing in the world is going to happen to a child, so you must be okay with children being hurt. A relevant parallel would be looking at the Chicago 400 and the movement to ease banishment laws, so people who are on the sex offender registry can more easily find housing, so they don't have to register weekly at police stations if they don't have housing. And really, it goes off of this thing of, if your framework is, if we make this law less punitive, children will be hurt, you're making the assumption that children are not being hurt now. And this is not true. Children are being harmed in the system we have right now, which really mandates that people, and if you've gone through the DCFS training, really mandates that you make a call if you have any suspicion. And it's also important to note, DCFS itself has been under a consent decree since 1995 due to its failure to provide adequate care for children involved in this system. There have been some very tragic cases of children dying who had caseworker involvement. And so it's so the thing that a lot of times myself and other people who bring up these concerns is we care about children's health and well-being. This current system we have is not preventing children from being harmed. It is not appropriately intervening when children are being harmed. It is a lot of times perpetuating harm. I can't remember if it's the Houston Chronicle or the Texas Tribune has done long-term investigative reporting about the child welfare to foster care to trafficking and exploitation pipeline. We know that there are issues with these systems. So questioning these laws is not because we want to see children harmed. We question these laws because children are being harmed and it needs to stop. Kind of just ending on this note, because the American Recovery Plan, I believe it's what it's called, was just signed into law. And this is landmark legislation that could lead to we're looking at the very real possibility that our child poverty rate gets cut in half, because so much of what this plan does is offer direct cash payments to families with children with very little means testing. What is this going to mean for systems that are all about maintaining power and social control? Like, are we going, and again, a lot of the funds allocated are to other organizations to provide for services. Are we going to use this unprecedented amount of funds to develop systems of supporting family directly that are really going to cut our reliance on these carceral systems of care? Or are we going to use all of this funds to continue to perpetuate these carceral systems of care? And again, I know we are going to be having a Q&A section later, so happy to take anyone's questions. And I've also included my email if later on you have a question and want to reach out. And of course, I've been in school very long. I have included all of my references. I'm happy to send my slides over, but that is my presentation. Thank you all so much.
Thank you so much, Elena. I think we were just kind of discussing, should we maybe just do the Q&A now, since it's prescient of like the time? If people have questions that are brewing, we can do a couple minutes now if you have anything that you would like to ask Elena, and then we can also maybe, if people come up with questions later, we can have it an open forum. But if anyone has a question now, feel free to unmute yourself and ask it. Going once, twice. All right. We'll think of some questions. Let's do this at the end. And I'm going to turn it over to Rafaela Sosa, who is going to move on to our next introduction. Take it away, Rafaela.
Yes, thank you, Justin. My name is Rafaela Sosa. I am also a Master of Social Work student in the advanced program at Northeastern Illinois University. So tonight I have the honor to introduce Dr. Arturo Carrillo, who also happens to be my site supervisor, which I'm very fortunate for that because I've learned so much from him. He is just very wise and knowledgeable on the Treatment Not Trauma campaign. So I'm very lucky to be a part of this coalition, the Collaborative for Community Wellness, also known, I think most of you probably know it by Treatment Not Trauma. So I'm just gonna go ahead and read the bio because it is a little bit long. I don't know that I can remember everything, but yeah, so Dr. Carrillo has served as a licensed clinical social worker, offering and overseeing community-based programming that offers free long-term trauma-focused mental health services for residents in Chicago's West and Southwest sides. So during this time, he has led the development of a community-based participatory research project with various community-based organizations and nonprofits to document the disparities in mental health access for residents on Chicago's Southwest side through the Collaborative for Community Wellness. The report titled Uplifting Voices to Create New Alternatives, documenting the mental health crisis for adults on Chicago's Southwest side was released in 2018. This was the beginning of multiple research initiatives that have documented the inequity of access to mental health services throughout low-income communities throughout the city. It has also been the impetus for continued policy advocacy to increase the investment in the publicly operated mental health clinics of Chicago in order to bolster the city's safety net to ensure mental health access, and ensure mental health access is a human right. So current efforts have focused on the creation of a non-police crisis response system based out of the existing public mental health centers through the Treatment Not Trauma campaign. He is currently serving as a director for violence prevention and health initiatives for the Brighton Park Neighborhood Council. So without further ado, I think he's on the call, right? Dr. Carrillo?
Thank you. Thank you
Want
for
to
the
make yourself
invitation.
known?
Well, hello, everyone. Thanks for having me. Thank you for the opportunity. I'm definitely very excited to be here among fellow social workers and future social workers. You know, I think as a social worker myself, you know, I really think about what role we play, not only in serving and supporting the lives of people and communities that we're committed to, but also just in general, what direction are our systems taking and what role do we play as advocates to ensure that these systems can be restorative, can be spaces for healing and support instead of kind of the punitive system and the carceral state that we currently default to in this country, right? So I thank you for the opportunity and the invitation on today's topic. You know, I have a presentation to share with everybody, and definitely I'm open to take any questions at the end. But, you know, I know, and I just want to applaud the leadership within the school, within the professors, the faculty, the students. You all have been really engaged in this effort. So I feel like I'm going to be speaking to the choir today. I feel like a lot of you have already heard about this campaign. I've been engaged. But you know, I really feel like what we do is continually look for input, and so part of today's conversation, I'd also like to be able to gather input and get your thoughts. We are in the process of revising policy and council orders as we speak. So any input that we could gather from you all today would definitely be incorporated as best we can in our campaign moving forward. So I know we don't have much time, so I'm going to jump right into the slides. All right. So, okay, just want to make sure we do this. Okay, now everyone disappeared on me. So just if someone could just confirm that they're seeing the slides verbally.
Yeah, you're good.
Yes.
Okay, great. All right, awesome. All right, so, you know, this, so by way of introduction, thank you for the introduction, Rafaela. You know, as I mentioned, you know, I'm a licensed clinical social worker by training and also a PhD. I've been blessed to be able to engage with many of your professors in the PhD program, so I know very well a lot of the faculty. Sorry, everyone.
It's okay.
So part of the efforts that we've been engaged with has been not only as social workers and advocates, you know, really using spaces in the public setting to advocate and demonstrate for why public mental health clinics matter, but also really basing our work in the research and the data, right? We really, and you heard some of the early research in the introduction that we were engaged with. I'm gonna share today some updated surveying that we've done citywide. They're really painting a very dramatic picture of where we are as in this city as far as mental health access. Um, you know, part of my research and just in general my view on social problems is taking a structural lens, right? And so I think we should, being that we're in a room full of social workers, start with talking about structural social work. I'm sure many of you have seen already structural social work applied in your classroom coursework, but I really wanted to highlight how structural social work has been kind of the backbone and the underpinning for some of our policy platform, as well as also just understanding of how this issue is the way that we're currently finding ourselves when we talk to mental health access. We talk about mental health access in the city of Chicago, right? I'll dive into that in a minute as well. But just really quick, for those of you who may not be familiar with structural social work, right? Structural social work is essentially a model of understanding society that views our society as a platform, right? This idea that if you see the top tier, the top box of this platform is the social relational space, right? It's the space in which we all engage with one another in our society, in our community, in our city. Each one of the pillars that you see underneath that platform are different social systems, right? These social systems that essentially hold up this platform, that essentially shape how our society is created in a way that allows us to interact in a certain type of way, right? And so, and finally, the third element to this conceptual model is the ideological base, right? So every one of those social pillars, the social systems are rooted in this ideology that essentially reinforces and shapes how these systems operate. On the left-hand side, you see the liberal paradigm. The way I like to think about this is, as an organizer, you think about the world as it is, and the world as it should be. So on the left-hand side, you'll see the world as it is, right? This liberal paradigm that recognizes that our social relations are based on classism, patriarchy, ableism, sexism, ageism, right? We could go through all the isms. The pillars that we're going to focus on today are not the same ones that are listed here, but essentially these social systems are developed in a way that reinforce and maintain kind of this social hierarchy and very oppressive culture that we live in. And of course, all of this is rooted in ideology that's composed of individualism, capitalism, inequality, pluralism, this idea of representative democracy, right? Does it really get us the types of policies that we need? And, you know, we have very smart people in the room here, so everybody knows the downfall, the limitations of representative democracy, and we've seen that play out in a very exaggerated fashion. On the right-hand side, you'll see this idea of the socialist paradigm and what creating a society with different ideological viewpoints and understanding systems in a way that can reinforce different ideals, and with the ultimate goal of creating a social space that is much more about equality and equity among all social groups, right? So just to kind of give you kind of a quick overview, how does it look like for our issue that we're here to talk about today? Right, when we think about mental health access in the city of Chicago, I'm going to just jump ahead to the next slide here. This is something I really want to get to, right? This is the system we have currently, right? We have a system in which the largest mental health provider is Cook County Jail, right? Essentially, we have a situation in which crisis response in the city of Chicago is managed by the police department. Essentially, the police department and policing is the biggest social service that we fund in the city by far, right? And why, right? Why does that, why is that, right? And so again, going back to this initial diagram here, I want to just again reinforce that the top platform here, the social relational space, we could name, and we could spend a lot of time in this area talking about theory. But I just again I'll just do a quick overview of this slide. We think about the social relational space as it pertains to the issue of mental health as one in which people are not granted guaranteed access to mental health services. Right, we have 4 social pillars that we've identified. There may be others that are missing here, but these are the 4 social systems that allow access to mental health services in our society. Of course, the medical system, the welfare system, the criminal justice system, and the education system are the 4 that we've identified. As you just saw in the previous slide that I showed, in our society, we continue to invest in the criminal justice system as the entryway for mental health services, just like we do with the medical system. And what happens, right? And we've seen that play out very dramatically here in Chicago with the reduction in spending in the welfare system, while we've seen also subsequently the reduction in spending in the education system, right? Farmer Emanuel famously not only closed 7 of Chicago's 12 public mental health clinics, but also closed over 50 public schools in his tenure as mayor here in the city of Chicago, right? All the while, the investment in the criminal justice system continued to increase, right? Actually, it's tripled over the last 4 decades. Per capita spending on policing has tripled. At the same time, again, the welfare system and the role of the city as a mental health provider, social service safety net provider for mental health services has been dramatically reduced. What does that look like? How does that translate to when we look at a map of Chicago, right? What we see in this map of Chicago are the communities that were labeled as the high economic hardship community areas of Chicago, right? These are the areas that have the highest rates of poverty, highest rates of unemployment, and every social issue that we could think of. These are the areas that are the hardest hits, right? Areas. So essentially, we're talking about low-income communities of color on the west side, and the south side, and the southwest side. When it comes to mental health access, and going back to the point previously identified through the slides of the way we're assessing the social issue, is that we're seeing the highest rates of behavioral health hospitalization. So this means when people are in a mental health crisis, where they are hospitalized at the highest rates are predominantly in low-income communities of color, predominantly Black communities on the west side and the south side of Chicago, right? So this is where people's entryway to mental health care is through the emergency department, through a crisis that requires hospitalization, not through preventative supportive services in the way that could prevent this, right? We're seeing that the areas that are, again, among areas of the city that have the highest levels of poverty are also the ones that see the highest rates of hospitalization. By comparison, you would see that the southwest side is not showing the same rates of behavioral health hospitalization, but we also, again, have to account for the rates of uninsured that we see in these communities on the map here. And where this research and where this campaign for us started was on the southwest side and mapping mental health needs on the southwest side, which, as we see as a block, has the highest rates of uninsured individuals in the city. So once again, what we're thinking about when we think about this issue and we think about mental health access in the city of Chicago, we think about a problem that is designed to be this way, right? And so what does that look like, right? Every year through budget season, our elected officials, again, this idea of representative democracy, essentially set forward the priority of spending on a yearly basis. And year after year after year, as I mentioned, for 3 decades, over 30 years, the amount of spending in policing has continued to increase, right? This is a dated number. This figure is a bit dated. Currently, our operating budget for the police department is closer to $1.7 billion. By comparison, you'll see the amount that's spent in all the other areas of the city, that all the other programs and departments of the city that, as social workers, we really care about, right? We would want the Department of Family Support Services, the Department of Public Health, to be able to receive the amount of money, a fraction of the money that the police department get, in order to ensure that, as social workers, as people who are interested in healthy communities, the types of investments that are necessary to support this work can be done in a way that would be responsible. Instead, what we get is scraps. So, and this visually really just identifies how clearly of an intentional disinvestment we have when we show on the map on this graph here that for every dollar that we spend for police, only 2 cents go to public health and only 5 cents go to the Department of Family and Support Services. And again, to emphasize the point, Rahm Emanuel in his first budget in 2012 decided that spending $3 million on 7 public mental health clinics was a bit too much. So that's where he chose to save money. And again, our elected aldermen all unanimously passed that budget. So once again, we're talking about a situation that takes us to this place, right, where we can have mental health treatment being done through the carceral state. All right, so where are we today? And this is kind of, again, going back to this point that this system is created in a way that can provide access for mental health services in a preventative, culturally competent manner to certain parts of the city, and can leave everybody else to kind of fend for themselves. So what we see, and this is part of our research, when we map out where therapists operate in the city of Chicago, and you see this very clearly outlined here in this map, is that the North Shore, the North Side, the near North Side of the Loop area, all those parts of the city have, on average, 4.3 therapists per 1,000 community residents. We're talking about 21% of the city's population has access to 4 or more therapists per 1,000 community residents, whereas the remainder of the city, where 78% of the population lives, we see 0.2 therapists per 1,000 community residents, right? I mean, you can't think of a bigger disparity when it comes to access to care than this map here. And it's been a very inconvenient truth for the city to acknowledge this data. We first did this analysis 3 years ago, and not much has changed. We just repeated this analysis in this last year. And so, part of what we see, of course, is it's an income disparity, right? A system is created to give access to people who have private insurance, who have ways to pay out-of-pocket costs related to counseling services. And as a result, as a profession, as a social workers, if you want a middle-class job, you essentially are left with very few options other than leaving the nonprofit sector and going into your private practice. And most of the private practice opportunities, as we see in this map, are in these communities and also neighboring suburbs like Oak Park and Evanston, right? So part of what we see, of course, is where and how a system is set up to give and create this level of inequality. So what we have here is so I just want to just jump really quickly into a recently released study that we were able to publish earlier this month, where we were able to collect surveys citywide to assess what the mental health needs are. And we really were intentional to want to assess what mental health needs are, especially now during this pandemic. We were able to get a robust sampling of respondents citywide, where 378 respondents were able to fill the survey out. It was an online survey that was conducted between end of August and beginning of March. And as you see the demographics here listed, I think we were really satisfied that we were able to have in this short amount of time responses from a diverse sampling. So it was really helpful to kind of get an understanding of what people's mental health state is during this pandemic in Chicago. And so what we find, and it may not be surprising to most of you, is that we were seeing a lot of mental health concerns being reported. 63% of the respondents recognized symptoms of anxiety that they were dealing with, and 56% recognized symptoms of depression. I'll share this handout in the Zoom and after I'm done presenting, so I'll give you an opportunity to kind of look through the data a little bit more in detail, but I just want to kind of go through this really quickly. One of the things that we were really intentional to ask was, how willing are people to access counseling services, professional counseling services? We really always want to emphasize professional counseling services. We know informal mental health supports exist in communities. We know that communities are resilient or forced to be resilient. And so, part of what we know is that, there's this kind of narrative that says, well, low-income communities of color, they don't want counseling services. They don't, there's this thing about stigma and people don't want to go talk about their problems with a therapist. So, we really wanted to see how true that was. And so when we surveyed, and this is very comparable to surveys we've done when we've surveyed in other times. We find this time around that 94% of the respondents answered yes or probably yes. They are very much, I keep saying it this way, like I just can't think of another thing that we could get 94% of the people to agree on in the city of Chicago, right? So this is really, really important for us to think about just the enormous and overwhelming need for mental health services in the city of Chicago. What we asked as a follow-up to that was, well, as a hypothetical, let's pretend, let's not make any assumptions here. If the city had city-run mental health clinics, that offer free services, would you go? Would you be interested in going? And 90% of the respondents said yes, right? Again, we said in the hypothetical because we just don't want to make the assumption that people know that the city runs public mental health clinics. And as a result, we were correct on that assumption. We found out that 73% of the people who responded to the survey did not even know that the city ran and operated 5 public mental health clinics, right? So, once again, there was 12 at one point. Actually, in the city of Chicago, there was once 19 public mental health clinics. And just going back to this previous slide here, every one of those dots, blue dots, are the locations of the 5 public mental health clinics that remain. And what you see as the other symbols there, the X and the triangle, those are the ones that were closed by the city, right? So let's just kind of take a quick minute to think about what it would mean if we had 19 blue dots on a map. Where would we put them? What impact and what difference would that make for the residents in those areas that right now, again, currently have to, fight over 0.2 therapists per 1,000 community residents, right? This is exactly kind of the point that we're really trying to hit home with. And again, this is just confirms what we were seeing in just the mapping and the geomapping that we were doing, is that people themselves recognize that there's not enough mental health services in their neighborhoods, right? 86% of the respondents said that. I could go down, well, we'll talk more about what the city's response to some of this data has been in the past if we have time, and I'm open to answer some of those questions. But it's been really disheartening, right, that the city's kind of knee-jerk reaction has always been, well, there's plenty of federally qualified health centers, as though that's the end-all be-all for mental health care. And of those FQHCs, as they're known, seem to be the default response by city officials when it comes to where poor people get mental health access in the city of Chicago. Again, not what we're seeing in other parts of the city as we see in the map. What are the barriers to care? Again, this is not surprising. This shows up time after time when we've done this survey. Cost is overwhelmingly the biggest barrier to mental health services. By comparison, 68% of people said cost. By comparison, only 11% of people said stigma. And only 3% of the people, the lowest ranked barrier, said that mental health services won't help me in any way. They do no good, right? So again, this is very much a convenient sample. We know that this doesn't necessarily represent everybody in the city of Chicago, but we do, of course, know that cost is a prohibitive barrier when we think about disposable income and what does that translate to when it comes to access to care for local communities of color. So I don't know if we have the time.
Today across CBS News.
I wanted to jump into, let me check my chat to make sure if we do have time or not. If someone could let me know. I had a 3-minute clip that I wanted to share, but if we don't have time, I'm happy to just share the link for people to review later. How do we get to understanding the Treatment Not Trauma campaign and how would that look like in the city of Chicago? I know that's the topic of today's presentation. I wanted to show a 3-minute clip on the CAHOOTS model because, part of the conversations after last year, we were able to claim a victory and be able to push the city to invest an additional $2 million into the public mental health clinics that exist. As I mentioned, not only were they cut, but they were also very much disinvested in, and essentially, expecting that eventually they would just kind of naturally fold or go away. And public pressure has really made a difference to keep those 5 public mental health clinics open, but also they just did not have the types of funding that was needed for them to be thriving. So that led us to kind of set forward on this idea of envisioning what something like Cahoots, and this is a model of crisis response that was originated in Eugene, Oregon, 30 years ago, over 30 years ago. That model of crisis response was something that we wanted to bring to Chicago, because again, when you see that overwhelming amount of mental health need, and this is prior to the pandemic, we know that people's first engagement with therapy is often in a moment of crisis, or mental health services are not considered until people are in that moment of crisis. And then people call 911 and the police show up as though that's going to make things any better, right? And so, for us, thinking about how we could envision a new system, a system that could really could really kind of ground something that we know is successful, and very much a model that many cities are now starting to copy in Eugene, Oregon. How can we bring that here to Chicago? And I'm very proud to have worked with Alderwoman Rosana, or as many of you know her, just Rosana from the classroom. It's great to work with a future social worker like her, and think about how can we push in city council for this to be a reality. And so what we came up with was a proposal that was introduced in September. This proposal was a $5 million plan to set aside for a non-police crisis response program, a pilot program that would have operated out of a 211 call center. We really wanted to think about an alternative to 911, knowing that, again, communities of color have a historic trauma when it comes to dialing 911 and getting police to respond to crises. And so giving people the option, the alternative to 911 was important for us. We wanted this to be part of an open planning process, one that had opportunities for community engagement and community input. We wanted to pilot this program out of 2 of the city's 5 public mental health clinics by staffing them with an additional 14 clinicians, 6 paramedics, and 7 peer support workers. And we wanted the creation of a community oversight board at each one of the 5 public mental health clinics. Once again, when the city had 19 clinics, each one of those 19 clinics had a community oversight board. And that community oversight board had representation from community to be part of the support and oversight for those clinics. And all those oversight boards had a citywide oversight board that had representation from each one of those 19 clinics. What the mayor proposed was not that. What the mayor proposed was setting aside only $1 million for a co-responder pilot program. Her plan was absolutely clear that the intention was to have a police officer show up to the door with a social worker. It just doesn't get any worse than that for social workers to be complicit with the carceral system, right? We essentially were, and the mayor's plan was looking to have police be riding along with social workers and with police officers, and that's something that other cities have done as well. The plan has been to operate this out of a 911 call center, and it was developed behind closed doors. It was developed through this closed door committee that was created by Rahm Emanuel and continued by Mayor Lightfoot, where essentially executive directors from bigger nonprofit mental health organizations and many others are designing this in collaboration with the police department. And it kind of also includes conversations around the consent decree and complying with consent decree expectations, right? So it was a very kind of troubling space for us to know that that's where and how this program was designed. And there was and has been no commitments to operate these crisis response systems out of the public mental health clinics. So just want to do a quick side-by-side comparison. What is the pilot that the mayor proposed in Chicago look like when we compare it to other cities? So we have Portland, Oregon, where you see an initial investment of $4.8 million. And there was a commitment to increase that funding over time. Albuquerque actually developed its own, not only a crisis response team, but a whole department, a mayoral level department that is now committed to managing and overseeing a crisis response program that is, again, that is publicly operated with city employees. They committed 2.75 for the first year. And again, also Albuquerque is under a consent decree, right? So, because you're the consent decree does not mean you have to operate from and continue to operate from the police as an assumption that is the intervention point. Albuquerque took an entirely different route and did not involve the police in their community crisis department. San Francisco, $16.8 million for a 2-year pilot program. Again, both all three of these cities have operated their programs out of the public mental health, of the public system. Portland and San Francisco are managing theirs out of the fire department and creating these teams through the fire department. Albuquerque, like I mentioned, through this independent department. One of the things, and we've had conversations with representatives from each one of these cities, one of the things that keeps coming up every time we bring up Chicago in the context of what they're doing, they are entirely surprised and very kind of envious of the public mental health system that we have. They wish they would have a public mental health system, because as they're starting to roll out these pilots in those areas, the obvious question is, once you engage people with crisis, how do you ensure that they get the follow-up care that they need, right? And unlike Eugene, Oregon, that does operate theirs out of out of a private nonprofit mental health center, Portland, Albuquerque, and San Francisco don't have that mental health infrastructure to support the crisis response, and Chicago does. So we really have a space to build from. This cut off, but this is a 6-month analysis of the Denver pilot for non-police response. In the first 6 months, they received 748 calls. They provided transportation for people in 44% of those calls, mostly to get people to homeless services, to walk-in crisis centers, or a hospital. I want to emphasize what we're talking about when we talk about these non-police crisis response is not the same type of transportation that will happen when a police shows up, where you can be involuntarily hospitalized when the police officer is present. Every one of these transportations are voluntary transportations, and this is very strong principle for the CAHOOTS model. People are met with compassion and care, and they can not be forced into any method of treatment or any sort of follow-up program that they do not desire to be a part of. Everybody's given absolute liberty to choose, with the support of the crisis response team, what kind of follow-up support or immediate support that they would like in order to treat their crisis, right? As a result, what we found in Denver was that nobody was arrested. In fact, no calls for police backup were made on any one of those 748 crisis calls. And that goes in stark contrast with the mayor's claims, right? The mayor, for some reason, in her budget address, kind of seemed to go out of her way to say that Chicago was just too far of and dangerous of a city to have something like, what is happening in Eugene, Oregon, and other cities to be implemented here in Chicago. Her proposal from the start was to involve police in every one of those crisis calls. And again, data from other cities are showing that is not necessary. So I'll just end with this. I'd rather just kind of wrap it up here, and of course have opportunity for input from every one of you. But as I mentioned, the emphasis here is public mental health clinics are the core of this campaign, and it has been since we launched this campaign back in 2016. Why public? 3 quick points, and I'll end with this. Sustainability, right? When you invest in the public sector, that money becomes incorporated into the infrastructure of the city. It becomes part of the infrastructure, and as a result, becomes much more sustainable. It can outlive any administration. The mayor can brag all she wants about the $8 million that she's giving to nonprofit providers to increase the access to mental health services. I have some serious issues with that model, but let's just give her the benefit of the doubt. Let's say that $8 million is really where the money should be going. The next administration that comes in could very much eliminate that, right? There would be nothing to, just like any philanthropy funding that goes, right? That money is there for a temporary amount of time and then can be shifted away to other needs as they become popular. So again, sustainability, when it's built with tax money for public infrastructure, you see a lot more sustainability over time. Quality, every one of public services in the city of Chicago is open to public scrutiny and oversight, public oversight. So unlike nonprofits that are only in theory responsible to the board of directors, what we see in public services is that public accountability is part of how and why services are given that sort of transparency, right? Nonprofits are not transparent to the public on what their service delivery models or any matter of questions that public may want to know about. Grants that are given to private providers do not allow for that sort of oversight. And when we talk about quality, we think about good paying jobs. We think about city jobs that have, I don't know how many of you people have heard about this thing. It's called a pension, right? city employees have pensions. So when you retire, you have retirements allocated by way of just your commitment to being a frontline essential worker. You know, pay rates and starting pay for clinicians in the public sector are much higher than that of the nonprofit sector. So our emphasis has always been, and we are happy to say that the city has conceded and made sure that those clinicians that are being positions that are being created for this pilot program are going to be CDPH public mental health clinicians. So some of you may have now the opportunity to enter into the public workforce as a clinician to be part of these crisis teams as the city rolls out this plan. And that's been a direct response to this campaign. And so, you know, many of you supported by signing a petition. We had some amazing quotes and support from faculty here at NEIU, as well as many of you who were supporting us by filling out this petition. You know, like I said, this push really made a big difference. And so for those of you who are interested in following our campaign, you can follow us on Twitter. And we've been using the Treatment Not Trauma hashtag. So I'll share this information and these slides with anyone who would like to see them after this presentation. So thank you. Oh, I'm just, okay, so, yeah, thank you.
I mean, I don't know how everyone else feels, but it's 7:04. I think we have time for a 3-minute video if people are wanting to see the video, but yeah.
All right, let me get that back up. All right, not a problem. Yeah, that'd probably be a great way for us to start a conversation, because the first time I saw that video, I was just like, my jaw dropped. So I'd love to get people's reactions as well. Somebody stop me if they cannot hear the audio.
Today, across CBS News, we've been taking an in-depth look at America's mental health crisis. We call our initiative Stop the Stigma. Nearly 4 million people in this country with severe mental illness go untreated. They are 16 times more likely to be killed during an encounter with police. Omar Villafranca shows us how one city is trying to change that.
There's a guy on River Road who I think would benefit from having Cahoots come visit him.
When a mental health-related 911 call comes in, a specialized team in Eugene, Oregon rolls out.
Pretty much everybody we see is, for one reason or another, in a state of crisis.
Manning Walker is a medic, and Laurel Lisovskis is a mental health crisis manager. The pair are members of Cahoots, crisis assistants helping out on the streets. They answer calls like suicide interventions and overdoses. They're unarmed and most of the time without police backup.
We always live as a team. Whoever is talking and making contact, the other person is observing.
They took our CBS crew on an exclusive ride-along. Their first call was for a woman they'd met before. They believe she's schizophrenic. She told us her name was Kayla.
Would you rather deal with someone with Cahoots or like a uniformed police officer?
Definitely Cahoots.
How come?
They don't, help you when you're in the time of need or when you're hungry or certain things like that.
Cahoots was founded in 1989. Last year, they responded to nearly 23,000 calls in Eugene and Springfield, Oregon. Denver is starting their own version of Cahoots. City leaders from Oakland, Olympia, Washington, and even New York City are all considering similar pilot programs. Tim Black is Cahoots Operations Coordinator.
We handle almost 20% of the entire external public safety call volume for our area. But there was such a dramatic need coming in through the 911 and non-emergency lines that there was a need for there to be this kind of behavioral health first response.
Let them know that you're out of your bed.
Cahoots team members are trained to de-escalate when responding to a mental health crisis.
Thank you guys so much.
A recent study found 25 to 50% of fatal officer-involved shootings involve someone with a severe mental illness. Eugene's police chief, Chris Skinner.
They don't need jail. What they need is they need to be able to be de-escalated from their crisis. They need a ride to a mental health facility or to a medical care facility or wrapped around with services. That's what the people need. They don't need to be going to jail every time.
A new way to protect and serve, and maybe save a life. Omar Villafranca, CBS News, Eugene, Oregon.
And there is much more CBS News coverage on the mental health crisis tonight on CBS News Radio and our digital platform, CBSN and CBSNews.com.
Okay, so I don't know about everyone else, but that hug at the end got me. I was like, if every mental health crisis can just end with a hug, it would be a different city, right? So yeah, I mean, any reactions, thoughts, and definitely open to any questions. And thank you, Elena, for also your amazing presentation. I'd love to see how these two issues kind of interact in this conversation today as well.
I mean, I will just straight up start with that. So my question is, I just want a little bit, I want to know what kind of conversations Treatment Not Trauma campaign has had around ensuring that this model is both police suspicious and DCFS suspicious and involuntary hospitalization suspicious. And even with the constraints of federal and state law, how you're working to ensure that someone who is calling in a crisis gets that hug and, you know, the connection to services without the state sanctioned control piece as much as possible.
That's why we wanted an open planning process. These conversations have not had any public input. It's all being done behind closed doors within the Chicago Council for Mental Health Equity is the nice title they gave it. And it really wasn't until there was a complaint filed with the Illinois Attorney General that that the Illinois Attorney General's office upheld that the complaint that this was in direct violation of the Open Meetings Act. So every one of these conversations and the planning process has been held by the police departments in conjunction with experts within the field, right? But not community voices, absolutely not community voices, and definitely not critical lenses, I would say, people with critical lens. So we are in the midst of actually having to FOIA. We have to FOIA to find out what is some of the protocols that they're starting to develop, as they've already developed a full-on plan and pilot that will incorporate police. So just to update everyone, the current plan that is going to be rolled out starting in July does involve 2 police teams that have a paramedic that will be from the fire department and a social worker from the Department of Public Health. In 2 police districts, there will be 2 police teams. And in 2 other districts will be non-police teams. One will have a fire department paramedic and a social worker, and the other will have a paramedic and a peer support specialist. But your questions are actually our concerns as well. First off, we don't see a need for any of the teams to have police. The city has held firm to that. And with the advocacy we have within City Council, we're looking to have an open public hearing on this matter to bring those questions into the conversation. We want to get answers to those specific questions from the Department of Public Health, from the police departments who are, again, working on this together. So we need to make sure that we can have that sort of accountability in this before it rolls out, because if it gets off to a bad start and the headlines start going out that people are being involuntary hospitalized and being referred to DCFS, then absolutely people will not trust the system either, right? So again, if our input would be considered in this, that would definitely be some of the things, but we have not been invited to any of the planning conversations.
Dr. Carrillo, I was hoping that you could maybe share some insight into, so when these clinics were closed, what happened to the response? Where did it go? And also, who is in this Chicago Council of Mental Health Equity? Are there direct service practitioners that are in this?
Yeah, good questions. When the clinics closed, there was no tracking of participants, clients, people who were long-term participants of the public mental health clinics and advocates said as much when these clinics were being closed. We are coming up on the 9th year anniversary of those public mental health clinics. I would like to invite everybody on the call. We are going to have an event to commemorate the closure of the public mental health clinics at the Woodlawn Clinic on 63rd and Woodlawn on the south side, April 12th at 4 p.m. Details are to follow. We want to have a public showing to ask those questions. Advocates warned us that people would die when those clinics closed, and people did die when those clinics closed. So this was part of people's community that was ripped from them. And that Woodlawn Clinic in particular was one of those clinics that really was a resource for the community. And so to answer your question, yeah, there was no tracking of where people ended up. As a mental health provider, I could tell you we saw an increase in referrals and people showing up for mental health services when those clinics closed. But again, it was disastrous. And you know, when this campaign started in 2016, we pushed back on every one of those aldermen who voted yes for that closure, for that budget. And unanimously, we were able to get 49 aldermen to sign on to a resolution to re-examine where public mental health clinics would have to be reopened. 49 aldermen cannot disagree with the mayor, and they did. All of them did when Rahm Emanuel's last term. Unfortunately, you know, candidate Lightfoot promised to reopen those clinics. Mayor Lightfoot has not. And so we are going to have that action and that event April 12th to remind her of that campaign promise.
Who's in the CC?
Oh, sorry. Yes, your other question. It's kind of a closed door conversation, so we don't have an exclusive list. You know, at the first meeting that opened up in October, we saw the names of people. So that includes NAMI, of course. That includes thresholds, executive directors, right, and administrators. And those are the two that come to mind immediately. Representatives from different hospitals and health providers, FQHCs, Esperanza Health Center, right? We have different kind of the mayoral allies that just kind of put it in that category. And so we requested at the first meeting records and minutes from the previous meetings that were closed to public. We're still waiting for those. So yeah, if we ever get them, we would love to share those publicly, but you know.
Is it also, I would imagine, maybe not an outside chance that a lot of these people that were referred for, that were clients of the closed clinics ended up in the system of these large nonprofits such as Thresholds, Trilogy, you know, any places like this that do take intakes, like that they filtered so far down the system that they were maybe homeless or involved with the carceral system or involuntarily hospitalized and then ended up as new clients of these places.
Yeah, I mean, the promise was that, and this is kind of Rahm Emanuel's and Commissioner Chalker, who now works for the Biden administration, their words were that there was more enough resources available, and the resources were even coming with Obamacare, and right, like this whole idea that there was no longer a need for public mental health clinics. And you know, all these years later, nothing has changed. We really haven't seen a change. And you're right. I mean, I think nonprofit providers and you know other mental health providers were able to take in some of the, and some of them actually you know received contracts as a result of the city clinics closing. But did that increase accessibility and guarantee that everybody who was part of the clinics continued care? No. And so that's kind of where we are today. And I've dropped a survey that I mentioned, the report. It's in the chat, so if people could take that handout and take a look at it.
How you doing, Doctor? I'm trying to. I must have missed it somewhere, but what was my question? It was so much to gather. I was just trying to get the statistics and read everything. So, what's your suggestion that what we're going to do now? I mean, what are we pushing for, or what the campaign is about? I mean, I know Raphael and Justin been talking about it in classes. so tell me, because I can see a lot of need as a social worker, but I'm trying to figure out like where we supposed to go with it now. I mean, and then I didn't hear you talking about when the mental health got shut down the first time, or the long time ago when they first closed them up, and like so that's what I was trying to figure out. So. And then my next question, so I would know how long this process been, right? They've been closed. I know, like you said, they never got nothing else, but the county jail was the that's where they all went, most of them anyway, but some of them, I mean, so that's my question. So
that's a good question. Well, what we want now is we want the city to have public conversations on this topic. I mean, to Elena's point, she's absolutely correct. Like, we do not want this to be and recreated in a way that can, be repressive and continue to harm communities. So our next ask is for a public hearing. We need a public hearing on this matter, subject matter hearing within the health committee. We've been pushing for that. We've been calling on Alderman Sawyer, who is the chair of the health committee, to have that hearing so we could bring these questions to the table, to have direct answers from the Department of Public Health, from the police department. Without that hearing, we're still in the dark. The impacts, as you're mentioning, of the closed clinics are still felt. We passed that resolution. We want action on that resolution. We want reopening of those public mental health clinics. And right now, as a next step, no longer is there an excuse, right? The excuse was always, well, there's no money to reopen public mental health clinics. Well, the city's about to get $2 billion from the federal government, right? The money is going to be there. What the city chooses to do with that money is a different question. The last federal relief that came through the city of Chicago was a blank slate, a blank check that was given to the mayor. The alderman gave her full authority to decide single-handedly what the money was invested in, and what she chose to do was spend 60% of that money on the police. Over $400 million of federal relief did not go to people, did not go to rental assistance. It went to wellness checks that the police department was supposed to be doing. $68 million was left unspent. They didn't know what to do with the extra. We were asking for $5 million and we were being told that there was not enough money, and they were sitting on $68 million. So if we want these clinics reopened, this is the time to act. If as social workers, we want those, positions to be granted for employment possibilities for us to work in communities that we know need the support, and to have those clinics be where we can be staffing and providing free care to anybody as a universal human right, then now's the time to act, because the money is on the table, right? And so again, $2 billion is going to be distributed in the next 6 months. So we need to act now, and that's where we're pushing our elected officials. Every one of you can call your alderman, and we could definitely work with your school. And of course, Rafaela and Lisa have been strong proponents within the classroom. Of course, Rosana is one of your classmates as well. So we really look for the support of everybody to make sure that we are heard.
Given Chicago culture, you think cahoots can work here? And if you do think that, tell me why.
Yeah, I mean, I'd love to hear other people's opinions. In my personal opinion, being 13 years as a clinician on the west side and the southwest side of Chicago, never once have I felt that in dealing with a crisis, I needed a police officer to be there right next to me. In 13 years of personal experience as a social worker, I never felt that situation. Now, I think it's important to emphasize that, like, her argument, the mayor's argument, to think that it doesn't work in Chicago, to me, is very problematic, right? Because certain people in certain parts of the country can get, the white glove treatment, and she's saying that in Chicago you can't. That to me is like pretty problematic. I'd like to understand why she said that, but I could be wrong, and that's just my opinion. So if there's others who think it may not work here in Chicago, I'd love to hear some of the rationale as well, because I think that we have to be ready for some of the pushback.
Thanks.
Mm-hmm. So Shelby, I'm sorry.
Oh, no worries. Yeah, I know there's a question in the chat for you, I was going to say.
Yes, I mean, any support that people want to provide as far as the scripts for the alderman, we have done phone banking. We can support any ward who is organized, and you could get a group of 5 people to just sit down virtually and make phone calls to people in their ward. We get a call list and have people then, engage in conversation with community residents. And then if they want to follow up with the alderman, we could patch them right to the alderman's office and give them kind of the script. So, elected officials could hear directly from their constituents. That's very important. So Shelby and anyone else would be interested in phone banking, I could definitely work with anyone who wants to do that.
I did want to move on really quickly and ask a quick question of Elena that was relayed in the chat, just so that it can be seen on the recording of this. So Emily, I'm not sure if Emily is here anymore, but she asked to Elena, can you speak to mandated reporting as a social service work labor issue?
Yes, there are a lot of parallels. I know that for many of you, you may have had, like me, very low paying jobs where you were a mandated reporter. When I worked in after school programs that were funded through 21st Century Community Learning Center grants, I made $9.75 an hour. And the thing about that is when your own income is so precarious, and yet it's also a job where you're fingerprinted. I was background checked through Michigan's licensing and regulatory affairs. And the thing about that kind of thing is that it really, people call because it's a CYA clause. I know this mom is perfectly fine, but her kid keeps coming to school without a coat. So we do have to call, because if I don't call, then I'm going to get in trouble. I'll lose my job. My employer will ensure that I won't ever work with children again, and it's that kind of thing. And of course, a lot of jobs within mandated reporting are not unionized. So, and not only does this include like social work, but just like after school workers, peer support educators, all the part-time mentorship people. Like there isn't a lot of labor organizing at all, so it's just so vulnerable. And this is a thing that my group found as we were working on the project is really a lot of times calling is a reflexive, I have to do this so I don't get in trouble. And of course, the thing about organizing, and of course in Chicago, the teachers union is really the example of this, is as there is more organizing within social services, and once we get to the point where we don't have to bargain as much, of course, like you always do have to bargain over like your wages and working conditions, but also that idea of like bargaining for the common good. People bargain over really trying to narrow the scope of calling DCFS or making duty to warn calls? Can that be like one of the things that happens as there's more organizing in the field? And of course, it also is this irony of people who themselves are making very little money are calling, and thus, ensnaring families who also don't have a whole lot of money into this system. So it's like just lots of dual oppressions really tightly intertwined in this.
Does anyone have any further questions for either of these lovely folks that have spoken tonight?
I also just dropped into the chat a Tribune article that featured a very tragic situation in South Chicago where a trans woman, well, the headline was "A police officer stabbed after responding to mental health crisis." When the reporter actually researched and talked to the family, what you found was a trans woman who was self-harming. Of course, the mom didn't know what else to do at midnight and called 911, and the police showed up, and as a result, this trans woman is now sitting in Cook County jails receiving mental health care in the men's ward, right? Like that's the outcome of calling 911 and now facing assault on police charges with a deadly weapon, right? Like this is what happens when and so for me, that's going to be this idea that the police, again, going back to this idea that crisis response, and this is the mayor's position, right, requires police. If a police officer is showing up with a social worker and there's a knife in the trans woman's hand, it's not the social worker who's going to take command and control of that situation. It's going to be the police officer. In this situation, the police officers, even though one of them was CIT trained, drew their guns. One drew their gun, the other drew a taser. Unfortunately for the individual, they were only tased, not shot and killed, right? But what we see, of course, is that this to me is going to be the litmus test in the future, right? When this happens again and that crisis response team that has a police officer shows up, you know, will the outcome be different? And again, I highly suspect that it will not change the outcome. The only thing that does not escalate situations further to perpetuate violence and harm on individuals is to just not have a non-police officer there. If you heard, the cahoots model does not have, no one's armed. And any of the crisis response teams that are being deployed throughout the country. So, take a time to read that article. I think the reporter did a very, very good job and just doing a deeper dive into the issue. And so I think that's just something else I wanted to kind of share for people.
And we do have Angeline has a question that they would like to ask.
Thank you for letting me speak. So my name is Angeline. I'm based in New York City, and thank you for whoever created this guide, Alternatives to CPS. That was actually a very good guide. And I'm trying to recreate one for New York City. And I am a member of PLAN in New York City, Parent Legislative Action Network. And we're working to abolish the child welfare system in New York City. I was a victim of the child welfare system. For years, I went through the whole process to CPR, through a TPR. Fortunately, my child was able to come home, so I'm very happy about that. So now I am here trying to help other parents to prevent them from getting in the system. And unfortunately, if they're in the system, we're here to help them get out of the system. So my question is, in trying to create an alternative to CPS in New York City, I realize there's some sort of struggle because we don't have a lot of community-based organizations. My struggle is a lot of these organizations out there are some way, somehow linked to CPS. They're either getting funding from CPS, they're connected to CPS, because I don't want to have to refer a parent where they're going to be dealing with mandated reporters. And it seems like I could say in New York City, and I've done a lot of research for that because I recently wrote a paper for Columbia University. I realized that a lot of the organizations out here are connected to CPS because that's how they get their funding. So I just want to know, and I know you guys created a list. I'm not sure if any of the organizations on your list are somehow connected to CPS. I'm not sure because I'm not based in Chicago. But I know in New York City, like everybody's getting money from the city or state agency. And when you're getting money from the city or state agency, somehow you're there to report families. So if I could get any help and assistance in that.
Yeah, that was actually the biggest challenge that my classmates ran into. Essentially, like pretty much most of the food pantries affiliated with the Greater Chicago Food Pantry are staffed by mandated reporters. We did wind up including the NAMI helpline, the NAMI Chicago helpline on our guide, just because there was just such a dearth of local mental health support lines. And of course, NAMI has gotten some well-deserved criticism over their own collaboration with police. And it really speaks to what Dr. Carrillo is speaking on about just the need to create non-coercive, culturally appropriate mental health services as a public good. What we were able to find, we did find one phone and text line for opioid treatment that was completely anonymous, and I essentially had to basically, text in like you would do as a client. And just keep in mind, there are, this would be a lot of these services are used by social service workers ourselves to just say, hey, I'm doing research on this. How do you operate within this mandated reporting context? But this was actually an issue that we ran into. We tried to really reach out to our own networks to find organizations other people could vouch for, or really try to focus on providing a service. But that is a challenge. And we spent most of our guide is really focused on the history of CAPTA, the text of ANCRA, trying to walk people through what are the underlying needs behind these things that are in the ANCRA definition for neglect. And we did not, invest as much into the resources because of the exact issue that you're speaking to, Angeline. It really is a challenge. The thing that was really helpful for us that might be helpful for you is that there's now just been this expansion of mutual aid networks in Chicago. So pretty much every neighborhood now has one, and we found a directory and we included it. That's definitely a thing to consider. What are the equally complex but not nearly as respected because they're not folded into nonprofits? What are the mutual aid networks, and do they have a contact number? Because a lot of times they can be the quickest to respond, and they're not tied to these systems at all in a lot of cases. But you're speaking to a challenge that we absolutely faced as well, Angeline. And I will just absolutely shout out Plan is phenomenal. Joyce McMillan, who is involved with Plan, is phenomenal. Really appreciate all of the amazing work that folks in New York are doing right now.
Thank you. And Strength and Bonds that was scheduled to be at Columbia University last week was canceled. And it will be, it was postponed. It will be rescheduled. So please tell all the people in your team to register for it, okay?
Yes, thank you. And thank you for showing solidarity to the graduate student workers at Columbia who are on strike.
We're a little past time, so I think at this point we should probably wrap up. Just wanted to share a little bit about GASSW that we help facilitate this event. Is the Graduate Alliance of Student Social Workers here at NEIU. We are an organization, a student-based organization of students in the Master of Social Work program. Typically fully elected by the student body of the master's program. Unfortunately, this year, due to COVID, we were kind of volunteer-based. This is something that continues on at NEIU, and as this is a building program, we are looking for folks to be engaged, and we're gonna need new officers because a couple of us are graduating. So if any of you are going to be around at NEIU and would like to be involved, either as an officer or a member, please don't hesitate to get in touch with either myself, Rafaela Sosa, who's on this call, or Lisa Salazar, or get in touch with just any of the faculty. And yeah, thank you so much everyone for coming. Thank you to Elena and Dr. Carrillo for gracing us with your presence and speaking. Thank you for all the work that you're doing here in Chicago and nationally. Both of these things really help to embody the title of this event, which is Engaging in Alternative Responses, because I think it highlights the ways that we need to look outside of the current systems. And both of these presentations did, I think, exactly that. If anyone else would like to share any closing words, take it away. But thank you so much, everyone, for being here. Also, a gracious thank you to Dr. Isetu, who allowed this to be our class for tonight. And thank you to everyone in that class for showing up as well. We really appreciate it.
We also wanted to make an announcement. Good evening, everybody. It's Lisa. I'm the treasurer for the GASSW. I will not be graduating, but I think I'll be left alone at the table. So please join in efforts and keep us going next year. So please reach out if you have any interest. But the plug that I wanted to give tonight is more geared towards Advocacy Day. I'm a little disappointed that it's not in person, especially for those of you that are graduating. But I am super excited that it's going to be our first ever virtual Advocacy Day. And it is the big event that happens every year through NASW. We're going to be sending out a flyer through Cody as a reminder, because I know the department has already given out a few shout outs regarding the event, but I do want to let everybody know to keep an eye out for that flyer to be coming out via Cody in the next few days. And I just wanted to let everybody know that we can get internship hours for attending. So please start putting in that time with your supervisors. Let them know if you need support from NEIU, from the faculty to get you the time off from your internship, please let us know, because we do want a strong presence that day. And then just a suggestion for everybody to kind of represent NEIU with our colors, or if you have any banners or anything that you could put behind you. Also, you could do that, or the background, the screen background that is the NEIU would be also a great way to represent. Anybody who has questions, please reach out about Advocacy Day. Thank you. And thank you everybody for a wonderful night. Really a lot of great work went into this, and I'm very pleased with the results. Thank you everybody for all your efforts.
Really appreciate everybody's time and for hanging out for an extra few minutes. Definitely tells us that you were very much invested in the material that was being offered. So thank you so much. Share it with your colleagues, right? Some folks were not on the call, obviously, and I know that they would probably appreciate hearing this stuff. So I've shared the YouTube link on our chat, but we'll also go ahead and send it over email to folks. Thanks, everybody. Have a great rest of the week, and hopefully we have a chance to see some sun.
Thank you so much. I really enjoyed this. Enjoy your evening, everybody.
Take care, everybody.
Thank you so much. Thank you so much. It's been wonderful to see my students, some really good old friends, and meet some new ones. Thanks, Justin, for bringing this up. And really, this is awesome.
Yeah, thank you so much for letting me
Yeah.
Awesome. All right. Have a good night. Thanks again, everyone.
Bye, everybody.